know through decades of research that what drives substance use is things like poverty, things like housing crises, things like trauma, neglect, domestic violence. Those are what drives substance use. Simply having access to sterile drug equipment is not going to drive substance use up in your community. My name is Venet-Rogers. I am the Harm Reduction Community Education Coordinator at Positive Pathways Community Services. So we service people who are considered to be at risk of or affected by or who are living with a diagnosis of HIV or Hep C and other sexually transmitted bloodborne infections. And we cover 2 geographic areas, Windsor Essex and Chatham Kent. I think a very fundamental part of our organization's role in this has been to bring awareness to the issue first and foremost, and doing so in a collaborative way with, other agencies who have, stakeholders invested in this issue as well. And a big part has been education. Very much focused on harm reduction, prevention of overdoses, prevention of any other kind of health impacts that maybe substance use has as related to drug use. But it's pretty much been awareness, education, and advocacy for, I think, community-wide changes. So harm reduction is this, it's this approach to substance use where we recognize that there are some health impacts related to substance use. And rather than focusing on a behavioral change in terms of trying to get people to be abstinent, if they're not ready to be, we come at it from a let's meet you where you're at. So we want to minimize those health risks, and so we'll provide you with the equipment that you need to stay healthier. We have at our agency the Yellow Umbrella Needle Syringe program. And people can come in and access any kind of equipment as it relates to injection drug use, inhalation drug use. So people oftentimes associate a needle syringe program to sterile needles, and that's certainly something that we provide, but we also do everything else that's related around injection use, inhalation use, like pipes, for example. But we also do condoms, lube, hormone kits for people who are on steroids or maybe medically transitioning because they're transgender, abscess kits for wound care. I started in archaeology and so I was very oblivious to sort of societally wide issues until I got involved volunteering for just a community agency in London, and I was a crisis line worker, and I recognized that a lot of the women that were on the line were managing their trauma through substance use. And that's really how I started making that connection between, trauma, neglect, and substance use and the barriers that they experience to accessing services. And from there, I started really doing advocacy around those pieces, and I decided to do a degree in social work at the University of Windsor School of Social Work. And during my degree, I got involved with Positive Pathways, formerly AIDS Committee of Windsor. And first I was working in education and outreach. I was doing online outreach on gay hookup apps and stuff. And there you also see the connection with substance use, stigma, people trying to really just kind of navigate dating life and insecurities around their sexualities and substance use and how that all comes into play. And then a position opened up in harm reduction, and I think that's really where I found my passion. It's really just getting at, the opioid crisis and trying to do education around those pieces and policy changes. In the 3 years that I've been in this position, I've definitely seen a change in our community's willingness to talk about substance use in general, And not just substance use in terms of like pointing fingers at certain segments of the population, but actually acknowledging that all segments of the population are using substances. Some is behind closed doors and some it happens more publicly. And before we used to focus just on the public, the blight of downtown, quote unquote. And now I'm seeing more shifts happening. And I see it in the willingness of people and service providers to attend my harm reduction-based workshops, where they're actually engaging in a conversation, destigmatizing substance use, recognizing that it's everywhere, it impacts everybody, and we need to humanize this issue. And I think we're starting to come together as a community to really make some really positive changes. I mean, I always use this example. When you go in the needle syringe program and you have someone who's coming in and they're requesting information on some sort of treatment program, we'll give them different options so they can make an informed decision. And then among those are abstinence-based or recovery-based programs. And certainly if they determine for themselves that this is an avenue they want to explore, we give them the material, right? So we are not opposed to abstinence. I think why people assume this is maybe because we have been advocates in abstinence-only approaches don't work for everybody. They can be detrimental to some people, and that we need to diversify the way that we see treatment. Harm reduction is also treatment. I'll oftentimes get people who say, well, if a needle syringe program goes in my community, people are going to start using drugs because the equipment is accessible. And there's lots of research that has shown that this doesn't happen. It's a myth, and people don't start just using drugs because now they have access to needles or a pipe. So I think an important part of harm reduction is really recognizing that people, even who engage in behaviors that you're not comfortable with, have basic human rights, and that no one can be mandated and forced to do something that they don't want to do. We also know that forcing someone into treatment if they're not ready has not worked. It doesn't work. People need to have some level of engagement, just like any other activities we do in life, to be invested in something. And so forcing someone is not going to work. If anything, I think it can just really make them feel more isolated and misunderstood and judged, and might stop them from reaching out if they feel like they might be forced to do something. So the war on drugs has been an approach that we have certainly emphasized, and we still do in North America. Countries across the world have traditionally used this approach, which is let's put more money into police services, incarcerate people, fine them, get at the supply and demand chains, all those pieces. And this has been going on for decades, despite lots of data that has shown that this heavy emphasis on criminalization isn't working. If anything, it might be making things worse. So we are creating cycles of poverty, for example, and that keeps people in a loop of substance use, unable to pay fines, therefore, going back in and into the criminal system, all of those pieces. Meeting people where they're at is really just coming into an interaction with someone who uses substances and leaving any agenda at the door, or any biases that you may have, and really just asking the person what do they need in that moment from you, with no judgment, with no shaming, and that I think is really important. It doesn't happen a lot in the lives of people who use substances. I think they're used to being maybe coerced or shamed or judged, and that often leads to them being disconnected from really important health services, for example. So sometimes harm reduction professionals are the only professionals in that person's life. They're the only connection they have to a service. And so meeting people where you're at, for me, is just really, really important in terms of making people feel welcomed, and having honest discussions and empathetic discussions. I think people with lived experience play a central, or should play a central role in our discussions about the opioid crisis. Without them, we would be at a loss as to the directions we go in, how feasible our strategies are, how realistic they are. I always encourage service providers who want to incorporate more harm reduction based policies to engage with people with lived experience who have use substances, who currently use substances. I think that's really important. I think we need to recognize that we need to provide them with a compensation for their time and engagement if we can. I think a really great example in our agency is our peer packing squad. Every Tuesday we have people with lived experience of substance use who come in and they make up the harm reduction kits that we distribute in our needle syringe program. And it's been a mutually beneficial program in that they are compensated for their time, but also their knowledge. You know, they've given us some really critical feedback in terms of, well, what's worked in the kit, what hasn't worked in the kit. Oh, did you know this pipe is also used for this, you know? And that's huge, that's really, really important. So I think we need to be creative in how we engage them. I think sometimes we expect this kind of like, you can come to a 2-3 hour committee meeting, and maybe some can, but some may not be able to, right? Especially, I think it's really important to engage people who are currently using, but that presents some challenges in terms of, you know, trying to keep a person who's engaged, who's in substance use, who's also maybe facing multiple other challenges in meeting their basic needs. How do you get them involved in a more structured program? Is there a way to make that more flexible? Is there a way of meeting someone where they're at? So yeah, I think without peers, we are going to go in the wrong direction. It's all of our responsibilities to address the opioid crisis. I think we all can play a small part or a big part, whatever. I think that it comes from service providers. I think the fact that more and more service providers are attending harm reduction based workshops in the past year, maybe because the pandemic has kind of driven them to maybe acknowledge that harm reduction might play a very important role because people are disconnected from services. But I'm seeing such a willingness. So service providers can start thinking about their organizational policies. How can they be more harm reduction based, or open to someone who is on Suboxone or methadone, for example, where traditionally the people who were seeking these types of treatments were seen as like quote unquote taking the easy way out. Community residents who are concerned for the welfare of their neighbors, family, and friends have a place doing advocacy, you know, accessing naloxone, distributing naloxone in their communities, engaging in campaigns like the Label Me Person that's always seeking peer lived experiences. You know, politicians, policymakers, everybody has a role to play because it is a community-wide issue. We can't point fingers at one another and say, that's your role, you need to change this. I think we need to recognize that if we work together and collaboratively with an open mindset to deferring opinions, I think that's how we're gonna get places.
Right.
I think your community is doing well in terms of really seeking out opportunities to bring awareness to the issue and educating themselves on the issue and connecting to, you know, harm reduction based service providers, treatment service providers for substance use to see, you know, what does your program look like? What are the wait times? All of these pieces to see kind of the ongoing depths of the issue and their role in it. And I think with the Windsor Essex Community Opioid Substance Strategy, I think has, you know, through their different community consultations, we're seeing a growing support for harm reduction based services, more money towards treatment services for substance use. And I think that really just shows a shift where we used to just brush this problem under the rug, say it's not my problem, it's their problem. And I think people are coming to the table and realizing that it's everybody's issue and we should all be talking about it. And I definitely see Windsor making some very important steps in that direction. Well, I think some ways that we could do a little bit better is I do see still quite a bit in our community some not in my backyard mentality, that what's called Nimbyism. And I think that that has played a role in sometimes delaying really important services that could be made accessible in our community, because I don't want to downplay the importance of community consultations. I think that's really important because people will therefore feel engaged and a part of this process. But there's certainly people where that engagement needs to happen on the long term. And I think I recognize the importance of that process, and it makes me happy that it's happening. But in the back of my mind, I'm always thinking about the people who are dying every day from overdoses as I'm trying to convince someone to be on board with us with, consumption and treatment sites, for example. I think stigma will feed into organizational policies, will feed into federal policies. I think if you treat a certain segment of the population because they have mental health disorders or they're using substances a certain way, the danger in that is if there's already this kind of view of they're immoral and problematic, then you're going to have very top-down approaches to policies that are very coercive, that really affect their rights in terms of just basic human being treated with dignity and with respect. And I think it's really important to recognize that our own personal biases, our own stigma that we have towards certain populations is going to translate in the way that we engage with them. And so it's really important to have these discussions. In my workshops, there's always a bit of an exercise in the presentation somewhere where we take an opportunity to reflect on what our automatic responses are when we hear about substance use, about someone who is using and on social welfare, someone who's using and a mom. And we really deconstruct that, because I think people can say, oh, I'm really comfortable talking with people who use substances, but then you throw in a scenario like a lady who's pregnant and seeking harm reduction equipment, and suddenly that's kind of their limit of acceptance, right? And so we have to really we have to explore that and untangle that, because that's a lived reality, and stigma and judgment in that moment can turn that person away from really important care and access to services. So the Label Me Person campaign, I think, does a really great job of really providing opportunities for anybody to have these important discussions about what are certain myths around harm reduction services, or around supervised injection sites, or around opioids and overdoses. And it does it in a way that's really compassionate and engaging and open, and we explore where those myths come from, and then we provide you with evidence-based information that challenges you to see past those, and to how these myths have been propagated societally without really any evidence supporting them. And I think it's a multi-pronged approach, the Label Me Person campaign. We haven't invested in just one way of doing things. Podcasting, lived peer stories being incorporated, the actual workshop themselves. I think all of that provides a different platform. So if you are a peer but you're not comfortable joining me in a workshop, then we can engage you in another way, maybe through a podcast episode, maybe just through you writing down your story. So I think that's really a unique approach and a really important approach.